When it comes to stabilizing factors, there are three things that can stabilize a joint. We have the articular surfaces, ligaments that would be found around the joint, and actual muscle tone around the joint. Now, the most important stabilizing factor would be muscle tone. And then we have the ligaments as the next important factor, and then least important is going to be articular surface. So articular surface refers to how the two bones come together. Are the two bones hand in hand? I mean, are they really a good fit? An example of a really good fit would be the femur, the head of the femur, coming into the acetabulum of the hip. That's a really good fit on articular surface. So the hip is a really stable joint when it comes to articular surface, whereas, say, the head of the humerus coming into the glenoid cavity of the scapula, that's not a good articular surface. So when it comes to articular surfaces, I guess it depends on the joint itself. The better the articular surfaces fit, the more stability that there's going to be there. But if the articular surfaces do fit really well together, you're going to lose the range of motion. Your shoulder has a greater range of motion because there's not a great articular fit compared to your hip. Your hip is a more stable joint, but you lose that range of motion. Now, when it comes to ligaments, the more ligaments that you have stabilizing a joint, the more stable it is. So you want to have a lot of ligaments there. But there are different types of ligaments. There are ligaments on the outside of a joint. Sometimes there are ligaments on the outside of the actual joint cavity. On the outside of the joint cavity. Sometimes the ligaments are inside the joint cavity. Sometimes the ligaments are actually, let me show you. Sometimes here's the ligament right here. It's on the outside of the fibrous capsule, so you can actually see the ligaments. Sometimes the ligaments are actually inside this fibrous capsule itself, and sometimes the ligaments are actually going to be inside the joint capsule itself, inside here. So there are all kinds of different types of ligaments that you'll see in these synovial joints. But the more ligaments you have, the more stable the joint will become. Now, when it comes to muscle tone, this is the most important thing when it comes to stabilizing a joint. The more muscles that you have running over a joint, the more stable it's going to be. And then the more tone that your muscles are, the more stable that the joint is going to be. And by muscle tone, you're probably thinking how nice your muscles look, but then muscle tone really is a partial state of muscle contraction. When your muscles are at rest, your nervous system is constantly sending signals to your muscle, telling some of your muscle cells to be contracted at all times. So every single muscle that you have right now, every single one, there are a few cells inside that muscle that are contracted at any given moment. And the reason for that is that then that way that muscle will be ready to contract. So every single muscle has this state of partial contraction, just keeping the muscles ready to go. And say I'm talking about the biceps brachii muscle. A couple of those muscle cells will be contracted, and then those muscles will relax, and then a few more muscle cells will contract, and then they'll relax, and then a few more. But that biceps brachii muscle will constantly exhibit tone, and then that muscle will contract when you actually want it to contract, and then everything will be fine. The only time your muscles do not exhibit tone is if you sever the nerve to that muscle, or if you were actually damaged your brain in the area that's controlling the nerves to your muscle. So muscle tone is a very important concept. Okay, now when it comes to the actual movements of your synovial joints, we have to define origin and insertion first. An origin is where your muscle attaches to bone, and an insertion is where your muscle attaches to bone, but there's a difference between the word origin and insertion. The origin is a place where the bone doesn't move. So if your muscles are going to be attached to two different bones, and the muscle will contract. One of those bones is going to move. The one that moves, the bone that moves, that is the muscle's insertion. The bone that doesn't move, that is considered the muscle's origin. Now that we have those defined, let's talk about the types of movements. We're going to use the word plane and axis interchangeably here. You remember your three different planes from Chapter 1. We have the frontal plane that divides the body in anterior and posterior sections. We have the sagittal plane that divides the body into left and right halves. And then we have the transverse plane that divides the body into superior and inferior sections, right? Yes, I know you remember those. So those are our three planes, 1, 2, 3 planes, or you can think of them as axes as well. We have movements that are going to occur along those planes. If we have movements that occur in our joints that don't occur in any plane, if we can't define it in a plane, we would call those movements non-axial movements. We would call those slipping movements, and those non-axial movements usually occur in bones that are flat, like your wrist bones, your vertebrae, and your ankle bones. So those would be your intercarpal bones, like between your wrist, intercarpal, between your ankle bones, intertarsal, and between your vertebrae, intervertebral bones. All exhibit non-axial movements. Uniaxial movements occur in one plane, like if they're going to just occur in one plane, like along the sagittal plane. An example of uniaxial movement would be movement of your elbow would occur along the sagittal plane. Biaxial movements occur along two planes, bi for two. Maybe something's moving along, the frontal plane and the sagittal plane. And multiaxial movements occur on all three planes, the frontal, the sagittal, and the transverse plane. Think of your shoulder here. You can move your shoulder in every plane. So these are our types of movements. And now we have another way to define movements. Are these movements going to be gliding? Are they going to be angular, or are they going to be rotation movements? In gliding movements, we have movements that are non-axial. We can't define them on moving on. We can't say they're moving on a plane. We would call them slipping. They're just going to be two flat bones rubbing against each other. And like I said before, these occur between your intercarpal joints, intertarsal joints, and intervertebral joints, between your wrist bones, between your ankle bones, and between your vertebral joints. And angular movements, this is when you increase or decrease the angle between two bones. And here I have listed the types of angular movements that we are about to go over. In a rotation movement, you turn a bone about its own axis. So you're rotating. And I always think about rotating a chicken. I always want to cook a chicken that way, but my husband just won't do it, and I don't cook, so I can't convince him to do it. One day, I suppose. Okay, let's look at these next little pictures of this lady. She must be paid a lot to do this. I wonder if it's the author of the book. Okay, here she is. Here are her hands. She's doing her gliding movements first. Here's the wrist bones. These are the intercarpal bones right here, and they're gliding past one another for her to do her pageant wave. She's waving, her wrist bones are gliding, they're gliding. These are slipping past one another in a non-axial fashion, because she could also jut her wrist back and forth. So that's an example of gliding. Here, she is flexing her neck forward, and the opposite of flexion is extension. She flexes forward, she's going along the sagittal plane, she's extending her neck back. And then if she goes even back further, that's hyperextension. We did this in class. You could always flex your whole body at the waist and then extend it to bring it back and hyperextend it into a back bend. We flexed our knees back, we extended them down. Hyperextension of our knees, we didn't do that. That'd be bad, really bad. You could flex your elbow forward and extend it back. We wouldn't hyperextend our elbows. That would be a bad idea. You could flex your whole shoulder forward and extend it back and hyperextend it backwards. We did this. You flex forward, extend to get yourself back up, and hyperextend backwards. She was pretty good for that age, eh? I bet she's always been skinny. Okay, here's flexing the shoulder forward, and extension is bringing it back. Here's flexing our knee, extending it to bring it back forward. We don't hyperextend our knees. Wonder how old she is. Okay, to abduct. When we do this movement right here, abduction. Abduction is along the frontal plane. We're moving along the frontal plane. Abduct. Think of abducting a child. You take it away. When you abduct, you take your arm away from the body and you adduct it. To adduct it, you bring it back. You bring it back. So abduct, take away, adduct, bring it back. When she's circumducting her arm, she's taking it away, drawing this imaginary circle here. You can also circumduct your leg by drawing an imaginary circle out here. And rotation. This is not an angular motion. This was a third type of movement that we could do. You're rotating a bone along its own axis. So she's rotating her head. She's turning it back and forth to rotate her vertebrae, or she's doing a lateral rotation of her leg by taking her foot out, and a medial rotation would be taking it back in. So she's rotating her femur along its own axis. Now, these are special body movements. First, we're going to pronate. If you're in supination, this is a special way to, basically we're talking about how the radius and the ulna are. In supination, the radius and ulna are parallel to one another, and if you're in an anatomical position, your hands are in supination position. And if you pronate, you're flipping your arm over, and look how the radius crosses over the ulna. Here we have our styloid process here of the ulna. We can see that here we have our radius. It goes down to our thumb. Here's our styloid process of the radius here. And it crosses over. See how we see this when we do pronation here? And so pronation, we've crossed over. Supination, remember you can hold a bowl of soup in your hand right here. Supination, pronation. We flipped over. It's the only things that we can do here with our hand. In dorsiflexion, we've got our foot up. In plantar flexion, we're pushing it down. I always think you want to plant a seed with your toe. That's how I remembered the difference between plantar flexion and dorsiflexion. You can also remember with plantar flexion, if you think about plantar warts, you get plantar warts on the bottom of your feet. But I don't know if that can help you remember or not. Plantar flexion, you're pointing down like a ballerina, and dorsiflexion, you're flexing upward. And these are feet special movements. Inversion, you're taking your foot inward, whereas eversion, you're taking it out. Tickle, tickle. With protraction, you're jutting a body part forward along the transverse plane. So actually, this is I think this is about the only example that I can think of along this transverse plane. Protraction of the mandible forward, and retraction is drawing it back. She does a really good job of this. Oh, look, she's got her ears pierced twice. I've never noticed that. And elevation and depression, if you elevate, you're going up, and depression is down. You can also do this with your scapulae down here. Opposition is a special body movement of your thumb, where you can take your thumb and touch each individual finger, and you can do this because how your trapezium articulates with your metacarpal here. I've blanked on the word for a second, but your trapezium and your metacarpal, how they articulate with one another. It allows you your nice little opposable thumb. Okay, and that's it for this lecture.